name's Shauna Taylor, and the safety program that I would like to implement is hiring a staffing coordinator that will ensure safe staffing ratios for our nurses. So why have a staffing coordinator? This can be a central person that will look at the hospital as a whole, and they'll be able to ascertain where and how many staff members need to be allocated to each unit and department. This will help ensure safe nurse-to-patient ratios, and evidence suggests that when you have a better nurse-to-patient ratio, it's associated with lower risk-adjusted mortality. It's also shown to help decrease adverse outcomes, readmission rates, and hospital-acquired infections. And all of the above will help improve your staff satisfaction, your patient satisfaction, and decrease the cost of care. So how are we going to implement this position? So we'll use the staffing coordinator. They're going to assess the needs and assign staff to all of our inpatient units based on a computer-based patient acuity classification system, and I'll discuss that in the technology portion. They're also going to be in charge of implementing the team nursing approach when needed, and I'll also talk about that later. This will be used when our patient needs outweigh our nursing availability. So the education for the staffing coordinator, they need to familiarize themselves with all of nursing in the organization, where all the nurses are employed and what departments utilize them and in what capacity. They're going to also need to learn the computer-based acuity system. They're going to have to learn and evaluate the staffing scheduling for each department, how many nurses and what are their required shifts for each unit in each department. They should spend time on each unit and department to assess their various needs, because all units are different. And then they'll need to learn the technology that's involved in the mass communication with the staff. So education for staff, I put this PROSI AdCore model just because I think it's important. They are not going to need a lot of education in regards to the staffing coordinator position, but they do need to know about the change. And so I think it's important for nursing leadership to explain the why to the nursing staff so that they understand that, we're doing this for them, and hopefully this will benefit everyone involved. But you just want to take the time to explain that we're changing for a reason. It does require everybody to have individual change, and that will have the organizational outcome will be based on each individual person being on board with this change. And so this is just kind of more for leadership and how they can explain what's going on and take the time to do so that you get more compliance. So how are we going to measure the outcomes of the staffing coordinator position? So this practice environment of the nursing work index is a way to assess the environment of the nurses are working in. And then, so it's almost like a nurse satisfaction survey type thing. And then you'll have a patient survey, which are the HCAP scores. And then we're going to measure quarterly measurements for the hospital-acquired infections, readmission rates, and adverse outcomes, and we'll keep an eye on that after we implement this change. So the Nursing Working Index, it's a scale that measures the characteristics of the environment that is attractive to nurses. So some of the subscales include staffing and resource adequacy, leadership abilities and support, and then nursing foundations for quality of care, to name a few, but these are specific to what I think we will get out of the coordinator position. And then we're going to distribute and assess this from the nursing staff at least annually, if not more often. And then HCAP scores this is a survey that's sent out to all patients to assess their experiences during their hospital stay. Centers for Medicare and Medicaid Services uses these results for public reporting and then also for value-based purchasing. But I think hospital administrators use these survey results to gather information about how satisfied the patients were with the care they received. So I highlighted the measures in blue that I think are pertinent to what our goal is. And so to name these ones, communication with nurses, communication regarding medications, responsiveness of hospital staff, discharge information. Did the patients understand their care when they were discharged? And then their overall rating and willingness to recommend the hospital. So Our goal is to have improved nurse to patient ratio. So when the nurses have fewer patients, then they're able to spend more time with them. And so communication with their nurses and regarding medications is crucial. Is the nurse able to provide education with unfamiliar medications during administration? How responsive are staff? So if they have less patients in a more controlled ratio, they are able to respond when the patient calls out and their needs are met sooner. And then discharge information and whether or not the patient understands why they were in the hospital and what they can do to prevent coming back will help with your readmission rates. And then, of course, overall rating and willingness goes with how satisfied they were with their care. So all of these we can really gather a lot of information on patient satisfaction from these surveys. So the overall change that we're looking for, so again, we'll have the central individual that has no bias to any unit or department. They're really looking at the bigger picture and where the needs are and how we can best utilize our resources. So safe nurse to patient ratios will be dependent or be determined on this computer-based system. And then again, the use of team nursing approach, it was talked about in a article I read regarding the pandemic staffing crisis. So they looked at how can they get creative in staffing the units and the departments when the needs outweigh their resources. So they would have a couple of main nurses that would take care of a larger amount of patients, but then they had all this ancillary support staff that would be assigned to, someone would help administer meds and there were several people involved in the ADLs, so bathing and toileting and stuff. And so they kind of worked as a team versus one nurse having a couple of patients. They had, a larger amount of patients, but they worked as a larger team. So an example they provided was the OR staff at this, I think it was a hospital in Texas. They were reluctant to get out on the departments and work because, it had been a minute. But when they started proning patients a lot, they developed a proning team, and the OR staff are really interested in becoming part of that team. And that's how they felt they could do their job out in the units, because they are knowledgeable in proper patient placements, and they were really able to help in that aspect. So it's about getting creative and how can we use our resources wisely when we need to, and it's kind of in crisis mode. But then also there are ways to do this in just everyday short staffing situations. So our stakeholders involved are, of course, nursing leadership. They need to be advocating for their nursing staff and talking to non-nursing leadership and the importance of investing in nurses. And they're also going to be responsible for ensuring compliance among all the staff members. And then you have your director and managers of each unit. They need to allow the coordinator to do their job and ensure that their staff are compliant again. I put nursing staff in here because I think they're very important, and they're huge stakeholders because they need to be open-minded to this change. They need to be receptive, and when they are open-minded and receptive, it makes it work a lot better, and it helps overall with the overall goal. And then your coordinator needs to be consistent and efficient when developing their staffing plans. Creative as well. You have to be creative sometimes when you're in a pickle, like over a weekend when you've got a bunch of call-ins. You kind of have to figure out how can we do this. And so when you have that one person, okay, so how I implemented the Lewin's model of change with this was during the unfreezing part, you're introducing your staff to the coordinator position. You're explaining the position and what changes they can expect with the schedules and their staffing assignments, because the staff are going to be potentially floated around to different units wherever the need arises. So you really need to prepare them for that possibility. And again, explain it is for the greater good of everyone. And once, they're on board and once they've done it a few times, then hopefully you'll have less reluctance. So the moving part, the staffing coordinator begins actually managing the schedules and staffing the assignments of the units. And then refreezing, just assess the implementation of this position and how it affects the patient and nurse satisfaction, productivity, cost of care. Are there any changes that need to be done to the position? Okay, so the technology, we're going to again use that computer-based patient acuity classification system. And then the coordinator will also need to use the mass text alert system to the nursing staff to share our needs, try to stay proactive in sharing what are the needs of the week, the month, and communicating with the staff ahead of time, and sometimes last minute if needed. So this computer-based patient acuity classification system was developed at the Children's Hospital of Los Angeles. So basically what happens is when the nurse starts charting all their documentation, so their interventions, their assessments, medication administration, all that information is pulled from that documentation and ran through a mapping catalog. The mapping catalog will calculate their acuity based on what has been documented throughout the day. So, and then that creates the acuity need for each unit based on how many patients and their particular acuity number. And then a dashboard provides the managers and our staffing coordinator with a quick view to assess any fluctuating acuity throughout the shift as the nurse's documentation changes. So if you're in the ICU and you have a patient downgrade to PCU or tele, as that nurse documents those different changes in the orders and their interventions change because they go from Q4 hour to Q8 hour, etc. That will change the acuity number, and so that they're able to see the fluctuating change throughout the day. And so if they can send nurses from one unit to the other, or send people home, or anything like that, they'll be able to manage that on an ongoing basis. This classification system also allows for daily, weekly, or monthly reports of productivity. So the future of nursing, obviously, I think this will, if you have better nurse to patient ratios, it's what all nurses want. They want to have fewer patients, not because they're wanting to be lazy, but because they want to provide the care that they want to provide. They want to spend the time that they can with their patients, educating them and doing all the interventions and making sure that all their needs are met. So this is going to improve your nurses' satisfaction. This will also help improve, with that, it helps improve retention and recruitment, which decreases the cost of hiring multiple nurses over and over again, doing orientation only for them to get, burnt out or upset and leave. And then you have to start this vicious circle all over again. So retention is huge for nurses because it helps with the cost of healthcare. And then with all of that, obviously the improved quality of care comes with the nurses being able to take time, slow down a little bit, and spend time and make sure that they're assessing their patients appropriately and intervening as necessary. And this, improves the quality of care, but then also improves patient satisfaction, and then all of it decreased cost of care. Here's are my references, and thank you very much for listening. Have a good day.